Hello and welcome to the VJ Hem-Onc podcast, where we will be shining a light on the top updates in myelodysplastic syndromes from ASH 2025. This episode will feature key trial updates, including long-term follow-up from the IMerge trial, an interim analysis of the MAXILUS trial, a Phase I/II trial of bexmarilimab, and more. As well as this, we'll delve into some of the debated topics and more controversial issues in the diagnosis and treatment of MDS. This podcast is part of the MDS channel on VJ Hem-Onc, which is supported by Geron. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. So let's head to our first speaker, Amer Zeidan, who will share his updates from the meeting.
So MDS has been seeing a lot of, important developments in the lower risk more than the higher risk disease. But in this ASH, I actually been involved in a number, of important presentations. The first one is called the MAXILUS trial, in which we are using luspatercept at the maximum dose. So luspatercept has been approved in lower risk MDS in patients both in the front line as well as the second line anemia-dependent or transfusion-dependent anemia. However, the drug is given in a titrational mode where you start with 1 milligram, you go to 1.33 and then 1.75. But what happens is many patients fall off during the process and they never escalate because doctors forget about the escalation. So in this Phase III trial that is a non-randomized Phase III trial, we are presenting the starting at the highest dose from the beginning. And the data we show is actually demonstrating very good efficacy and very good safety. So I think that potentially could allow people to start with the highest dose from the get-go, which would be very important. Another presentation I'm giving on MDS in the lower risk is a subgroup analysis or a secondary analysis from the IMerge trial, looking at the use of imetelstat. And imetelstat is an approved drug in refractory relapsed AML after refractory relapsed lower risk MDS after ESA failure. So in this analysis, we actually look at the correlation of the imetelstat-induced neutropenia and thrombocytopenia and the correlation with transfusion independence. And what we show is that patients who do get thrombocytopenia and neutropenia early on have a higher chance of achieving transfusion independence, which reflects basically on-target mechanism, which is very reminiscent of what happens with lenalidomide in deletion 5q lower risk MDS. So this could allow people to use this as a predictor for response, but most importantly, for people not to get too scared when the patient gets thrombocytopenia or neutropenia, because it's part of the mechanism of how the drug works. And the last oral presentation I have in MDS in ASH is actually in higher risk MDS, where we are looking at the use of a new monoclonal antibody called bexmarilimab, which is an anti-cleaver 1 antibody. This is against macrophages. It leads to activation of the macrophages against the MDS cells. And we are showing data focus on TP53 mutated AML, where we show high response rate and durability of responses. So it's still a relatively short follow-up with a limited number of patients, but the data is very encouraging. And based on this data, actually, we are proceeding with a randomized Phase II/Phase III trial to test a combination of bexmarilimab with azacitidine, which will be a global registrational intent trial, which is a significant unmet need in high-risk MDS because we are still stuck with only HMA monotherapy. There were a couple of other presentations I'm involved in, which is a subgroup analysis of VERONA trial that looked at aza-ven versus aza alone, and unfortunately was negative for OS, where we're exploring subgroups where there might be more benefits, such as patients who have excess blast and patients with certain mutations.
Next, Valeria Santini will share further data from the IMerge trial on the long-term survival outcomes of imetelstat in lower risk MDS. Following this, Professor Santini will discuss a post-hoc analysis from the COMMANDS trial, which compared the efficacy of luspatercept to epoetin alpha in lower risk MDS.
The IMerge trial is a study that is evaluating transfusion independence achievement in patients with IPSS intermediate or low risk who have high burden transfusion dependence, so more than 4 red blood cell units in 8 weeks, and is comparing imetelstat, a telomerase inhibitor, to a placebo. So the trial was successful. 40% of patients treated with imetelstat achieved transfusion independence longer than 8 weeks versus 15% in the placebo arm. So the drug has, it's very interesting because it may indeed induce long duration of response. The majority of patients achieving the primary objective of transfusion independence for 8 weeks will have 6 months of transfusion independence. And finally, of all the patients, the intention to treat patients, 18 will have a transfusion independence longer than 1 year. So we focused on this subgroup of patients because we wanted to understand whether this long transfusion independence was mirrored by longer survival. So in the intention to treat, all the patients versus placebo did not show a significant prolongation of survival. But when we look at the more than 1 year transfusion-independent patients, you indeed have a signal, especially after 42 months of survival. So the study was not powered to evaluate overall survival, but there is a trend to obtain a better overall survival in treated patients. Now, this is just the beginning. We have to understand exactly the characteristics of patients, whether they had other treatment after imetelstat, but it's an encouraging data. Also because this drug is endowed with disease-modifying effect, meaning that the variant allele frequency of the somatic mutation present in the patients is decreasing significantly, and this correlates with the response. We had a look of long-term survival in COMMANDS. The COMMANDS trial is a study that compares the efficacy of luspatercept to that of EPO in patients who have low-risk MDS and are transfusion-dependent. And the primary endpoint, the primary objective, is to verify after 6 months the achievement of transfusion independence plus longer than 12 weeks, plus an increase of hemoglobin of 1.5 gram deciliter. And that's something that is seen in 60% of cases, so in comparison to 35% of patients treated with EPO. So having said so, we analyzed in the oral communication that is given here at ASH 2025, we analyzed which were the patients who were more prone to respond. And what we saw is that indeed treating patients with the early characteristics of the disease, meaning higher hemoglobin level, of course, on the threshold of transfusion, so below 8 or over 8 makes a big difference. So the patients with higher level of hemoglobin, who have a lower transfusion burden and who have a lower serum EPO level, are the ones who are responding in a very high proportion of cases, nearly 80%, versus much lower cases, again, in EPO, but also compared to patients who have different characteristic of the disease. And this is also reflected in the duration of response. So the idea that we have is that if you treat early these transfusion-dependent patients, if you do not wait that the disease is too, let's say, advanced, even not progressed, but advanced, you can obtain really outstanding results in terms of achievement of transfusion independence.
Now we will move on to discuss the Phase III VERONA trial. This trial evaluated venetoclax plus azacitidine in adult participants with newly diagnosed higher-risk MDS. The study did not show a significant survival benefit, and Jacqueline Garcia will share her insights into the interpretation of these findings.
I would say VERONA was a really important study. It taught us how we should try to adjust how we run clinical trial protocols for high-risk MDS in 2025. We've evolved how we take care of MDS patients and our expectations. So I would say the punchline is the addition of venetoclax to azacitidine is not for everybody, mostly because we don't see a change in survival benefit. However, there are a lot of details that have not yet emerged that require additional analyses, and we might have to learn from ongoing and recently presented real-world data to really supplement what the trial could not offer or provide yet. So as an example, during the life expectancy of this clinical trial of VERONA, which was a trial for intermediate and high-risk patients, we found that it did not meet its primary endpoint of overall survival. It was essentially the same 22 versus 21 months for study versus standard of care azacitidine. We learned a few things. One, the combination regimen was not as toxic as everyone was worried about. The rate of febrile neutropenia was, like 23% versus 17%, which tells us we can take care of our patients. The scheduling was very safe. Importantly, there was no early treatment mortality, which was excellent. During the life expectancy of the clinical trial, our recommendations for higher risk MDS changed. And so based on BMT-CTN or a randomized study in the transplant setting, we learned that what our patients should get in frontline is really transplantation. So during the process of the clinical trial, our expectations have adjusted and have increased for patients with high-risk MDS, meaning the chemotherapy or cytoreductive regimen that we give is merely a bridge or what we provide en route to a transplant for patients. Now, the majority of patients may not be eligible based on age or comorbidity, but it is something that we learned. So in this clinical trial, Verona, we did see that despite not meeting the survival endpoint, we learned several things. One, there was a better modified overall response that included complete remission, which was the same in both cohorts, partial remission, and marrow complete remission. The marrow complete remission is a bit of a topical concept in itself because we removed it from the IWG 2023 response criteria. But the idea is that means it's less than 5% blasts and could represent an opportunity to then transplant somebody who has adequate disease control. And so in this clinical trial, we saw that the modified or overall response was higher with the study arm. And if we're wondering why didn't it translate to survival, I think it's several things. So one is patients were not as sick with study treatment. And so there is a chance, because it's overall survival, that people got additional therapies afterwards that might have led to them being able to have a longer survival, meaning our first regimen did not make them too sick, and so they could get a second-line therapy if indicated. A second thing that we found is that, unfortunately, while we wanted to focus on higher risk MDS patients, we included intermediate risk as well. And while they're very worthy of investigation, what we know about venetoclax is it's really a blast reducer, and that's what we learned in the acute myeloid leukemia setting. In MDS, it's a stem cell disease, and it is a different beast when it's less than 5% blast versus those with excess blasts. When you look at the forest plot curves, when we look at multi-variable analyses, we're able to appreciate that with the study arm, by overall response, we see that it trends in favor of the combination. And when we take a look, and it was not powered for overall response, it was a secondary endpoint. But when we look at the forest plots for overall survival, it trended with a hazard ratio of 0.8, just barely crossing over 1 for those with greater than 5% blasts. So my hope was if we had patients that were truly higher risk, higher or excess blasts. I think that we have not fully answered the question in the context of this randomized clinical trial because it's underpowered for this, to ask the question of whether or not those with excess blasts greater than 10%, greater than 5%, or those with high or very high risk disease, do they benefit from a combination approach? I would argue that there's certainly flirtation of that based on the trends. It just did not meet significance. So I would say across the board, I don't universally recommend giving venetoclax. I would be very strategic on individual use. If it's being used to bridge someone to transplant, I think it could be worthwhile to consider because it does not add more toxicity. But if it's used as a sole agent, I don't think that it's necessary at this time from what we know. The last thing I'll say is what we've learned with the additional follow-up is only about 19% of patients went to transplant. That really speaks to that we had a really higher risk patient population that was older. When we look at the transplant data, it looks like patients are doing well overall. What we need a little bit more analyses on, which we hope to do for the manuscript, is to show were there any differences based on the first-line regimen that they received. All I could tell you is that from what we know with the data available is that on this trial, after their first treatment assignment, twice as many patients in the azacitidine placebo group did end up getting venetoclax at the end of the day. That might have helped to contribute to the curves over getting close to each other and not being significantly different, meaning they eventually got venetoclax despite not getting it in the beginning. A second thing that was presented at the SOHO meeting in September is that for patients on the study arm, because it was doublet and there's a little bit more myelosuppression or lower cell counts, there was a bit more azacitidine reduction. So did we potentially underdose patients on the study arm because the other arm was placebo, and so we had to dose reduce azacitidine in the protocol? I think there was a lot of factors from inclusion of intermediate risk, patients getting post-trial venetoclax, the reduction of the azacitidine in the combination arm that contributed potentially to the survival benefit being unseen.
Daniel Wiseman speaks next on the results of the Phase II Amer trial of ASTX727, an oral formulation of decitabine with cedazuridine in CMML and other MDS-MPN overlap syndromes.
I've presented the first results of the UK randomized trial called AMO, which stands for ASTX727, which is versus hydroxycarbamide and best supportive care in MDS-MPN overlap syndromes. So this was a phase 2 trial in which we randomized patients with MDS-MPN overlaps in a 2-to-1 fashion to either receive ASTX727, which is an oral formulation of decitabine with cedazuridine, which is a cytidine deaminase inhibitor, which allows it to be taken orally. And the standard of care for pretty much all of these diseases for decades has been hydroxycarbamide, but that's not particularly disease modifying. The results are not very good, doesn't particularly delay progression, and it can actually exacerbate the other cytopenias that these patients often have by virtue of being overlapped. So we know that hypermethylating agents work in these diseases. What we don't have or didn't have is any prospective randomized data against that standard of care. So we took 77 patients recruited across 13 sites, geographically spread across the UK. A very simple design, and we just treated them in a 2-to-1 ratio with 727, or they were able to receive best supportive care that in almost all cases included hydroxycarbamide. And we gave them 6 cycles of ASTX727 or control, at which point those who were responding could continue until progression. If they weren't responding, they would come off study. There was no crossover from the best supportive care arm. We met our primary endpoint, which was great. So the overall response rate was 54% for the experimental arm versus 27% for hydroxycarbamide. Not very many CRs. It's about, I think, 10% versus 3.8%, which was basically one patient on the hydroxycarbamide arm, which is actually fairly modest data, but probably what you'd expect for a hypermethylating agent in these diseases. But what was really pleasantly surprising, I think, was that the secondary endpoints of survival were all met with a significant advantage in the ASTX727. For example, overall survival for the full modified intention to treat population was 24.2 months for ASTX727, but only 17 months in the hydroxycarbamide arm. And the hazard ratio was 0.45, which did reach significance. And we saw the same and sometimes better figures for progression-free survival, transformation-free survival, and again, slightly better results when we just looked at the majority of patients with CMML who took part in the study. So, I think the question is, why have we seen an advantage when other studies with hypermethylating agents, for example, the Phase III Dakota trial of IV decitabine, why have we seen significance? And, I think one of the answers to that is to do with the fairly permissive dose reductions and dose delays and the better tolerability of the drug. This is an oral agent. IV decitabine is quite hard going for these quite elderly comorbid patients. And I think that's reflected in the fact that the median number of treatment cycles received by our patients was 10 versus around 5 in Dakota. And we were quite liberal about dose reductions from the initial 5-day to 4 to 3, and often down even to 2 days per cycle, almost a sort of maintenance type approach. And as such, we've got responders still going on cycle 35 and beyond. And so I think that's probably part of it. And the tolerability profile was, as you might expect, this drug has been used widely in the US and elsewhere. And, we saw 24% of patients with 727 suffered febrile neutropenia, typical, but very manageable hematological toxicity. So, we're really quite excited by this. It's a small advance, perhaps, but it's the first randomized survival advantage for any drug in any MDS-MPN overlap syndrome for almost 30 years, the first one since hydroxycarbamide itself. And so, we believe that this should be a new standard of care for advanced proliferative MDS-MPN overlaps beyond just CMML who need treatment.
Finally, we turn back to Valeria Santini to discuss some of the debated and controversial topics in MDS that were discussed at this year's ASH.
We had a very good discussion and confrontation during the Momentum Symposium of MDS Foundation. We actually discussed several hot topics in the management of MDS, both high risk and low risk. One debate was regarding the diagnosis, and I'm starting from it because I think that a good diagnosis can provide an optimal therapy. Diagnosis of MDS is complex, is based nowadays on morphology still, but the debate was exactly focusing on whether morphologies should still be the standard of diagnosis or whether we can shift to molecular characterization of MDS. Now, of course, the debate is open and hot and lively because we still do not have all the MDS classifiable by NGS by presence of somatic mutation. But that was quite interesting, as well as the second debate. The second debate was even more specialized in a way because it was discussing whether all patients with germline predisposition to MDS, so an assessment that is not routinely performed yet, should undergo a pre-disease therapy, so a prophylactic therapy. And this is something really for the future because we do not have the data of all patients. And of course, depending on the kind of germline predisposition that is present in a substantial proportion of cases when studied routinely should be performed. And especially we should be very careful in when and how proposing stem cell transplant. So these were the two debates. And then we had a discussion. I actually had the presentation regarding the failures in high-risk MDS clinical trials. Unfortunately, in the last years, we did not succeed in finding a combination of azacitidine and other drugs that could improve survival in high-risk MDS. So what are the most promising drugs in high-risk MDS? I don't know, because I think we still stuck with azacitidine or decitabine as the main treatment and the standard treatment. I hope that we can find in the future better designed study that will clarify what we can do to improve our patients' survival and live lives.
Thank you for listening to this podcast. Head over to vjhemonc.com to see our full coverage of ASH 2025. Be sure to follow us on X at VJHemonc and subscribe to our podcasts on Spotify, Apple, or Podbean. Stay tuned for next week's episode that will feature more updates from ASH 2025.